Thank you, Saurabh. Um, so please make it workable from here. Yes, but they are not visible here. Yeah. So the topic is IVF at 40. Is it mandatory? So 40 in Indian scenario is something which is 46 in Caucasians. So we should understand the all the studies which we are having, all the researches, they are from the UK, USA, and all the European countries, and that is why we are following those guidelines. And our Indian guidelines now we are making in the process, and we have made some of them by the Indian Society of Assisted Reproduction. But still, we are following ICU guidelines or ASRM guidelines. So, my presentation would be the age and fertility dilemma, biological reality. What is a biological reality, especially in Indian scenario? Success rate, counseling. How do you counseling? Because counseling is a very important part. ART law in India. What does it say? After 2021, we have the law right now, and challenges and limitations at this age. What are the alternative options we are having, and what are the key takeaways? So, the age and fertility dilemma. We all know that there is a changing landscape right now, and most of the even our children, they because of career, because of some other reason, they postpone the marriage as well as postpone the pregnancies. And that is not good in Asian women because our ovaries age faster, around 6 years than the Caucasians, and we follow the their lifestyle. Average age of first time IVF patient now has risen to above 35 worldwide, and India is not behind it. We are having first visit after 30 years. So, and they think about the IVF after 35 years. 5 years they keep on roaming from one center to other center. If you see these data, then you can see that there are around 20% monthly conception chance at the age of 30. So the fecundity rate is 20% when the lady is less than 30 years. But it dropped down to 5% only once she reaches at 40 years. So that's a very eye opener data. And the what is the biological reality? If you see the quality, so it's not only the quality, it's not only the quantity, quality also declines with the age. And it happens like 25 to 30 years are almost same. After that, it starts declining comparatively at a slow rate. After 35, steep decline you can be, it is seen. So whenever a lady comes with a AMH of somewhere around 1.5, you should ask her to go for IVF, because otherwise you won't get the good number of the eggs. Then what would you produce a good number of the embryos? And that is why that is the time when you should tell her, okay, one or two cycle we can go for IUI or something else. Later on, you have to keep a plan B in your mind from today only. So, not only this thing, there are so many other things that come up, like a comorbidities. Higher the age, and I always explain the patient, right now your uterus is at least normal. You might develop adenomyosis, endometriosis, fibroids, and blah, blah, blah. And then the surrogacy, we all know, is such a difficult task nowadays. Then, forget about it. 35, 45 lakhs is like a cost right now for the surrogacy. And we should never forget male factor, because we all know T plus is a time when the DFI increases. And that is why DNA fragmentation index. You can see the normal semen analysis. But morphology is normal, motility is normal, number is normal. Why do you worry about 40, 45, whatever age? But no, it's not like that. If you go for the DNA fragmentation index, that's really high in 40 plus cases. So always go for it, because now the WHO 6th edition has added this DFI also in the testing for a high age group. So now understand what is AMH and ovarian reserve. We all understand AMH. Now the AMH is pretty common. And we should understand when to do this AMH. AMH is anti-malarial hormone, which tells about the ovarian reserve. And any day of the cycle, you can get it done. But you need to be a little, cautious when patient is taking oral contraceptive pills because there will be false low AMH levels. Then, what data shows about the success rate? So here you can see when the patient is 35. You minded these are the uh, you know, uh, studies in Caucasians. So in the Indian scenario, whatever written is 35, you take it around 30. Okay, so when the less than 30 years, it's a 50 to 55. And where it is written 40, that means it is 35. Okay, so when patient reaches 35, and in my experience, I mean, I'm 30 years of my practice in reproductive medicine. I have seen, you know, 30 to 33 is the time when, I have seen most of the patient, they have a reserve less than 2. And right now, in AIMS, one of my friend, her daughter-in-law in AIMS, and just for to know their ovarian result, these are all girls from the gynae and other department. They have done their AMH, and very few girls have the AMH more than 2. So this is really alarming. If you understand, either stress or change in lifestyle, these are the factors that our AMH is declining faster. Then reading the number right. Okay, what we say like a per cycle, what is your success rate? But see, whenever you counsel the patient, you don't say per cycle because this is not the and. If you have done IVF once, this is not the and. You can go for the embryo pooling if she really wants her biological child, and that is the right of every woman. She should have her biological child if she is having a reasonable amount of the AMH, I mean AFC or number of ovarian reserve. So, always give this, make it mentally prepare. You might take a few more cycles in comparison to other ladies. And that is why you should not tell the now there are only 5% chance and don't make her, so negative thinking. And you have to tell the number like that this is your number and this much of the cycle you might need to take to get pregnant. Okay. There are few more things which you can tell about, like the frozen embryo transfer. That is a good option. PGTA, I mean the pre-implantation genetic testing, aneuploidy screening. That's also a good thing which you can think about it. So the counseling is very important. It is mandatory because as per ART law, you should have a counselor in your center. So that is why counseling is very much necessary, especially in the high age group. Now the when the counseling is needing in a long in a proper way. So it's like a when you initiate any ART cycle at any age, you need to counsel the patient. Very low AMH or poor awareness, you have to counsel. Give them a proper figure. Don't give them a false hope. कि अरे मेरी वो patient first time में हो गई थी तो आप तो हो जाओगे. Don't tell. Always give a figure which is worldwide reasonable. Partner with male factor infertility. If there is a both the partners have something common factor, then you have to counsel about the male factor also. If she is already having some failed cycle, then again, or recurrent implantation failure, recurrent abortions, these are the things which we are getting more and more in such patients, or any other associated like fibroid or adenomyosis, endometriosis, so many other things. So the what effective counseling should offer medical reality. So you have to go for the testing, proper testing, male partner as well as female partners, ovarian reserve, TFI. Then the legal and ethical awareness is also very important because now the age is defined 21 to 50 years for a female, 21 to 55 for a male. Okay, and the age of marriage is 18 years, so you have to wait for 3 more years. So I think the government has decided regarding this because they might going to increase the age of marriage later on, and that is why they have put this age 21 years because in a MRKH syndrome there is no fun of waiting 3 years, but still we have to wait. Okay, so, our legal form framework is the ART law, where the women aging 25 to 50 years and male 21 to 55 years. And there is a mandatory written consent. All the forms are given in the law. You have to get them filled. Due filling of the is necessary, and the counseling is compulsory. So, what are the challenges? Number one, poor ovarian response. There are very high chances of getting the poor ovarian response. You have to tell the patient your cycle might be cancelled. You know, then increasing miscarriage risk. Obviously, there are more chances of aneuploidy, and multi-cycle burden is there because she has to go more and more IVF cycle make to get a one golden egg. And there's a high aneuploidy rate. So if she wish, you can go for the aneuploidy testing. But again, if she makes only one embryo, I don't think, I mean, is it reasonable to go for the aneuploidy testing? Because we all know there are false results also. Okay, then the thin endometrium is another factor, because uterus, there is a aging, there are fibrosis and other factors which might cause the thinning, but it's not always there. Then the obstetric complication, which is very important thing, because these may have a gestational diabetes, gestational hypertension, and a lot of other complication are associated. And there are some ethical, social, and financial limitation also, especially when the patient comes in a age of like 49 years, husband is 50 plus. Then you have to think what the baby, I mean, what would be the baby's future, especially if one is already having some serious medical illness. So that is really important. You have to think about the baby which you are going to give. So there are some social consideration also regarding like male factor and immunological factors that you have to always keep in the mind. Then alternative option, so always give all the option in a platter. जैसे हम अपने होटल में जाते हैं तो वो अपना मेन्यू कार्ड देते हैं, similarly you have to put everything. These are the option, these are the pros and cons, these are the like chances, which is having better, what is the cost of the treatment and everything. Let them decide. Okay, that's very important. So but you have to tell what is like a success rate in which and these are the things: embryo adoption, frozen on embryo, altruistic surrogacy, ovarian rejuvenation is another emerging thing, but it's not evidence based. So always take in a writing that it is only for the research purpose, and still I want to get this rejuvenation therapy. So that's a very important thing. And the adoption should always be in your list of advice. Always, whenever there is a question of egg donation or surrogacy, always put one option, adoption, on your paper. That's very important. Okay, then PGTA might be a game changer for women over 40. See, I have used the word might because it's all depend how many embryo you are finally ended up with. And that is why pooling is very important thing, where you can get a good number of the embryos, so that you can choose this aneuploidy screening thing. So this is the clinical decision algorithm in women over 40 seeking for IVF. So patient, if she comes at the age of more than 40, always look for the ovarian reserve. If the reserve is good, go for IVF with Onyx and consider PGTA. And if the reserve is low, give her a donor egg option also. And just discuss, thorough counseling is needed in such cases. But if it is very low, then it's always good to push the patient towards the donor eggs. Okay, or embryo adoption if the male factor is also there. So the if IVF mandatory at 40, so I think everybody can answer now because you have seen so many things, and the direct answer is no. It's not mandatory, and but there are a lot of other things you have to keep in the mind. And then give the all the option, all the pros and cons, all the percentage of success rate and other things, and then let the patient decide, let the couple decide what they really want. But that's very important that IVF is preferred when the patient is around 40 years. And time is the fertility, and PGTA adds value if you have good number. So IVF is not the only path, but choosing the right path is very important, and nothing can give you the guarantee. So always tell, even with the donor egg, there is no guarantee that you will get the baby in the first attempt. So that to maximize the IVF success, you consider PGTA. Okay, start early. That's very important. Age matters a lot. That is the only known factor, which you decide the quantity as well as quality. And this is the age-based clinical guidelines at a glance. You can see. So the best time is less than 35 years, and as patient age is 40, the donor option is good one. In my view, age is just a number. Biology is the real. Many a time, 40 to 43 years lady, they give a very good number as well as good quality eggs. And many a time, 25 years will not give you the good quality egg. So this is like a, you have to keep them. So I think one chance should be given to every lady who is having a reasonable ovarian reserve. So these are the key takeaways for the clinical practice. Success rate declines sharply. Own egg IVF around 20%, 40 to 42 5%. So it's such a, sharp decline. Counseling is mandatory and meaningful. It should be meaningful counseling. PGTA is a valuable tool if you have a good number of embryo in your hand. Time is fertility. Time is very, very important. So push the patient at the right time for the IVF. At least ask for the, fertility preservation. Those who are young and still not want to get married, they are looking for the right partner, just tell them for the oocyte freezing. And even if she's a married, no, and they don't want a baby right now, ask them to get their embryo freeze, because they can use at any age. Okay. And always tell the alternative options. So helping couple at 40 is not about false hope, it is about the informed hope. And with these words, I am really thankful to organizers and these girls, because I have flight, so they have a little prep on my talk, and it's really
Thank
thankful
you
to
so
them.
much, ma'am, for a very excellent talk.
If there is any question in the audience, I'm ready to
You have
answer.
covered each and every aspect of topics, ma'am, very nicely. Thank
Thank
you,
you.
ma'am.
Thank you, everybody.